So ADHD through the lifespan. We used to think that ADHD was a childhood disorder, and now it's obviously clear that it's not a childhood disorder, that it's a disorder that affects kind of all ages. And I'm going to kind of talk about how it presents differently through development. Also, we used to think of ADHD as a psychiatric disorder and treated by specialists, and now clearly that's not true. I mean, that's the minority of cases. So I'm going to try to give you a broad overview of ADHD through the lifespan and try to aim it at what to look for, what might be useful in primary care. And hopefully there'll be time for questions, which people always have one or two questions in this topic, right? Next slide. These are my disclosures. I do consult for industry a little bit, and my research is funded by NIMH. Next slide. I think I already said this. Next slide. Just to give you like a brief overview on the epidemiology of ADHD. Estimates of how prevalent it depends on which measure you use and where you do it, but there's some consistency. Kind of a ballpark figure is about 10% of children in the United States have ADHD, about 6% of adolescents, and about 4% of adults. The important things to look for, though, isn't how prevalent it is, it's how it's treated. The group that's least treated are the adults. Most children with ADHD, 2/3 of children with ADHD are treated. Whether they're optimally treated is another question. But the biggest group that is untreated are the adults. It's important when you think about ADHD, it's a developmental disorder. It starts in childhood. And if you have like 100 7-year-olds and you follow them up to the teenage years, 60% will still have the full syndrome. If you follow them up through young adulthood, about 45% will. So, I mean, the good thing is that it gets better over time in terms of the symptoms. The bad thing, though, is people with ADHD, that puts you at risk for lots of other things, especially if it's untreated, and we'll talk about that. The other just issue about the epidemiology is the gender difference. It used to be very heavily predominant in males, and that's kind of changed, although still in children it's more prevalent in boys. When you get to adolescence, the gender ratio is even, and it's even for adulthood. So again, one of the most common disorders, you'll see that in every setting, and there's lots to do about ADHD once you recognize it. Next slide. Even though people tend to think of ADHD as a relatively new disorder, it's really not new. It's been around a long time. This is Heinrich Hoffmann was a German psychiatrist who wrote this book. It's kind of one of the first child care guides. And he portrayed these pictures of children that were misbehaving, and then all sorts of terrible things would happen to them. And so in the center is a picture of Fidgety Phil, that is this hyperactive boy that wouldn't sit still, and he's a little clumsy, and he pulls the tablecloth off the table, and you see how happy the parents are with him. But his clinical descriptions are really vivid of, kind of a very active boy. Der Strumpeter, Sloppy Peter. He's a boy with kind of electric hair that's sloppy and unkempt, has developmental coordination disorder and awkward. Again, just, these pictures, really are kind of consistent with what ADHD looks like even today. Next slide. The first medical description of ADHD, the English pediatrician George Still gave a lecture at the Royal Society of Medicine, and he described these kids that had problems with attention and normal IQ. And it really fits with what we call ADHD. He didn't have a good label for it. He said they had defects in moral control. So you can understand why that didn't catch on, and it's not on T-shirts or parent groups. But next slide. The disorder has gone by different labels over the years, depending on what we think the etiology is, or what we think the primary symptoms or impairment are. So in this country, it was really the pandemic of encephalitis and then afterwards where there were children that had hyperactivity, seizures, intellectual disability, and ADHD was thought of as a brain damage syndrome. Later, when it was more broadly, people were more broadly aware of ADHD and they realized most of these kids didn't have frank evidence of brain damage, they softened the definition and called it minimal brain dysfunction. A lot of them had what's called soft signs, they were clumsy, they had minor EEG abnormalities. And then as neurodiagnostic techniques became more sophisticated, we realized that a vast majority of children didn't even have those characteristics. And in the 60s and 70s, the emphasis was on hyperactivity and then later attention as the primary underlying symptom. We've been calling it ADHD for the last 20 years. Recognizing that there are both attention symptoms and hyperactivity symptoms, but different subtypes or formulations. Different labels, but essentially the same disorder in terms of the presenting symptoms and the course. Next slide. So this is what I think of when I think of ADHD. So these are 7-year-old kids that are in our summer treatment program. We have one in Seattle Children's called C-STAR. This is one that we had in Chicago called STAR. So you notice they're mostly boys. They're all boys. The counselors are all female, but the children are all boys. And these are kids with ADHD that's really obvious, okay? So I have a diagnostic clinic where we train people, subspecialists in diagnosing and evaluating ADHD, and I always say, keep the 7-year-old in mind, but the farther you get from a 7-year-old, the more complex and difficult the diagnosis is. You know, when you have a 50-year-old man or a 4-year-old girl, they look very different than this, and we can talk about some of those differences. Even though this is what we think about ADHD, again, it looks very differently in many different ages and in different genders and in different populations. And one of the most important characteristics of ADHD is extremely heterogeneous. And so we'll talk about, you know, how you tease apart what's ADHD from other diagnoses and how that influences your treatment plan, which is really the complexity. It's not so much does someone have ADHD or not, it's like ADHD and what else, and what do I do? What do I treat first? Next slide. So I just want to talk a little bit about diagnostic criteria. I think everyone's familiar with the symptoms. And again, when ADHD has two main clusters of symptoms. There are the inattention symptoms, you know, losing things and being disorganized, which you don't see usually. You see the consequences of that. And then there are the hyperactivity symptoms, which you might see, especially if it's a severe case. But most of the time, ADHD, especially if you're in a brief office visit, you may not see the hyperactivity, and so you have to depend on others, whether it's the parent or the teacher, to tell you if they have the symptoms. But one of the issues with the diagnostic criteria for the symptoms is everybody has these symptoms, depending on the time of day or where they are in their life. But you have to evaluate if they're developmentally inappropriate. You know, all 4-year-olds have ADHD symptoms, but we don't diagnose ADHD in all 4-year-olds. But you know, kind of terrible twos continued is kind of a nice way to think about what ADHD is like when you see some of the same behaviors in someone who's older. So I want to just go over the criteria for diagnosis because there's a lot of confusion. Symptoms do not equal the diagnosis. And it's, you know, even, you know, I think we emphasize you getting Vanderbilts and rating scales, and I think that's kind of actually led to, in some places, overdiagnosis of ADHD. So just what are the criteria? Well, you have to have symptoms, okay? And the symptoms are based on your judgment, but they're probably the easiest to assess in children. You can assess symptoms by using a rating scale and by observation and by history. And we say you have to have 6 or more if you're a child, or 5 or more if you're an adult. And again, it's a developmental disorder, so the symptoms start early, but many times symptoms can be covered up or people can be unaware of symptoms. I mean, it's kind of ironic. ADHD is this disorder that has cognitive effects, and when you're working with an adult and you say, what were you like as a child, they don't remember. And so it's really a problem getting the childhood history of symptoms. DSM just says they have to be present. And so we often infer if they're present by the impact of those symptoms. The third, the C category is really important, the impairment. And impairment means they're really having trouble in life. And it needs to be across settings. It can't just be in one setting. But your judgment as to the clinician to decide if the impairment is across settings. In children, we usually think about school and home and peers. In adults, we think about work, relationships, self-esteem. But those are the areas that you look for impairment. Lots of people, they read about ADHD and they identify with the symptoms, but they kind of miss the impairment piece. And so that has to be there. If we're treating ADHD without impairment, then that's performance enhancement, which is another issue. And then this is the D criteria, or E, is really important for primary care. The symptoms have to not be due to something else. And again, the primary care physician is like the first person to really rule out those other things. Is this ADHD, or is this a different psychiatric disorder, or a different medical disorder, or a social phenomenon that's leading to these symptoms or impairment? And then the other thing is just the time course. Many people display ADHD symptoms in response to stress. I mean, kind of the classic is after like a parental separation or changes. So the symptoms and the impairment have to persist for a while. Next slide. So ADHD usually doesn't come by itself. When it does, we call that ADHD simplex, and that's about 25–30% of the time it's just ADHD, but mostly there are other problems. I mean, a typical problem list would be 3 to 5 in someone who presents with ADHD. And it varies by age. So in children, the most common comorbid characteristics are behavior problems and learning problems. So behavior problems, oppositional defiant disorders, kind of like minor behavior problems, tantrums, blaming others. Conduct disorder is more severe, someone who's lying and stealing, skipping school, those kinds of things. As children get older with ADHD, they're more likely to have internalizing problems, like mood and anxiety problems. Again, that's a consequence of ADHD. If you're doing poor in school and poor socially, and you realize life sucks, you're going to be demoralized. And the clinician has to discriminate, is this demoralization because of the ADHD, or is this depression? Someone that has vegetative signs and anhedonia and other symptoms. And I think there's a lot of confusion there. Other common comorbid disorders, voiding disorders. So in our child clinic, we see a lot of kids. The risk factors for ADHD are also risk factors for enuresis and encopresis, and that's often the first thing we'll treat. You have a child with ADHD that smells, they're not going to do very well in school and socially. And actually, I've seen children where that's actually causing the ADHD because the child is trying so hard, for example, not to having a bowel movement. They have toileting refusal, and that's led to other problems. So again, be aware of what often comes with ADHD and think about how you treat it. In adults, I don't think I have a slide for adult comorbidity. Next slide? Maybe I do. So in adults, the most common comorbid characteristics are substance use and mood and anxiety disorders. And there's a gender difference slightly. More males with ADHD, adults have substance use, more females have mood and anxiety, but you see both all the time. The next version of DSM-5 is going to have an expanded list of symptoms, I predict, because one of the things that we've learned is that there's an emotional part of ADHD. Kids with ADHD, just like they have trouble controlling their movements and their motor behaviors, they have trouble controlling their emotions. So you see this mood lability. And that's part of ADHD, and that actually responds well to treatment. The adults with ADHD will tell you that they just feel like emotionally everything kind of upsets them. And it's not depression, but it's in relation to ADHD symptoms that are kind of causing this. So like 30 to 40% of people with ADHD have emotion regulation problems. And oftentimes that's what they come in the clinic for, and they say that. But then when you get the history, you find out that it's their impulsivity, their attention that started first that kind of led to this. Next slide. The other associated problem that I think is really part of ADHD are sleep disorders. And one of the issues, especially in primary care, is this a primary sleep disorder that's resulting in ADHD? This is someone that has, for example, obstructive sleep apnea, and they're snoring, and then that's contributing to their lack of cognitive functioning and attention and alertness. Sometimes that happens, but most of the time that's just a correlate. But then there are other kids that they can't shut their brain off at night when they want to go to bed. And that's really their hyperactivity that's contributing to the sleep disorder. But what we see is that people with ADHD, especially children, tend to have more variable sleep. They tend to have difficulty with sleep onset. And if they're taking a stimulant medication, they tend to have trouble waking up in the morning. So those are things to be alert for. When I think about ADHD, I mean, it's interesting, I've been doing this for a while. We used to think of ADHD as a school disorder, and we used to treat it with Ritalin twice a day. And then we realized it's not just a school disorder, it's an after-school disorder, it's a social disorder. And then we started using the long-acting stimulants were developed like Concerta. But now we think of ADHD as a 24-hour disorder. And you don't want to sacrifice nights for days to go well. You really have to look at the 24-hour period and what you can do to help with that. Next slide. So why is it important to identify ADHD and treat it? Well, the outcomes for ADHD are bad. It's not just doing poorly in school. People with ADHD, they tend to do worse in terms of their occupation. They tend to struggle in their relationships. In terms of medical issues, they tend to have more unwanted, unplanned pregnancies. They have more sexually transmitted diseases. If you're in the emergency room, you'll see consequences of ADHD. People with ADHD don't wear seatbelts. They tend to, not know their limits. Russ Barkley is a psychologist that has done a lot of work on ADHD. He's actually calculated that the life expectancy for someone with ADHD is about 9 hours less than someone without ADHD. I mean, a lot of it is, behavioral, what their habits are and their risk factors. But this is a really important disorder in terms of the range of outcomes, negative outcomes. And it's also really important in that it's one of the most treatable disorders. And we'll talk more about that. Next slide. So I said substance abuse often comes with ADHD, especially untreated ADHD. So this is longitudinal studies just show that teenagers with ADHD tend to use illicit substances earlier, and that almost half of adults with ADHD have a history of substance use disorder. And this is an old study. I bet it's even higher now than that. There have been some very good meta-analysis where they've looked at thousands of people that were treated with ADHD, and what they show is that treatment does not increase the risk of substance abuse, which is a really helpful thing to know. I mean, some people are worried about, do I give a stimulant to somebody that's at risk for substance abuse? And really the evidence from the meta-analysis is that that's not a risk factor. It actually lowers the risk of substance use disorder. But still, if you have ADHD and a substance use disorder, you're in a group that really needs more treatment for both, not one or the other. And one of the ironies of ADHD is your treatments depend so much on who you see and what door you walk into. And we see lots of people that are ADHD's undertreated because they're in a substance use program, or they're in a trauma program, or they're in something else. So, next slide. So getting back to the evaluation in primary care, I always tell our residents to think of SIMS: symptoms, impairment, mimics, comorbidities, and strengths. So the mimics, again, are all the things that could be contributing to the ADHD symptoms that aren't ADHD. So in kids, the most common mimics are sensory impairments. Is it a hearing problem? Is there a visual problem? It's not sensitivity to labels or sensory integration. That just means you've seen an occupational therapist, but that's not really part of it. But having a primary perceptual disorder should be ruled out. So, always check that. Sleep deprivation is really common in ADHD. If someone is tired, they're going to display ADHD symptoms. They're going to be easily upset. Medications, antihistamines, anticonvulsants, lots of medicines affect attention, and so we need to pay attention to that. You always start, an evaluation for ADHD always starts with a very thorough history and physical and a family history. They're really good clues from the family history. So I always ask the parents, did you have any learning or behavior problems as a child? I don't say, were you diagnosed with ADHD? And find out that they struggled in school or they had behavior problems or somebody mentioned something that makes you think of ADHD. In terms of if you have a child with ADHD, 30 to 40% of the time, there'll be a first-degree relative with ADHD. It's often the parent, and it's often missed. And many times they still have ADHD, and that really impacts your treatment. When you're treating a child with ADHD, it's the parent that administers the treatment. The treatments for ADHD that work aren't things that are done in an office. It's not counseling, it's not occupational therapy. But the things that work, and we'll talk more about that, are behavioral interventions either delivered by the parent or teacher, or medication, which is also delivered by the parent or teacher. Next slide. So we have medical mimics, but then there are also social mimics. So social mimics can either cover up ADHD or make it seem worse. And you as a primary care physician are in the best position to rule out the social mimics, hopefully, because you know the family, you know the school, you kind of know what's going on. But whenever there's a poor fit between the child and their abilities and parents' expectations, that can result in kind of a mimic of ADHD. So Mercer Island ADHD, I don't know if you know what that is. So Mercer Island ADHD is someone that is really an excellent student. They just got a B in honors calculus, and so they're taking Stanford and Brown off their college list. Usually there are people that, again, that present with ADHD, but they don't really, is that really an impairment to not get into, your very exclusive school? Sometimes it is and sometimes it's not. So anyway, the social mimics are really hard for subspecialists to evaluate because we don't know, the environment that they're coming in. Next slide. So I think about 80% of ADHD should be treated in primary care, but 20% of the time I think you need a subspecialist, either because it's really subtle, like is this a Mercer Island learning disability or ADHD, or is this really ADHD, in which case you might want to get more testing or more other things done. But the other comorbid conditions which are hard for primary care are the psychiatric comorbidities. All psychiatric disorders impact attention. And does somebody have ADHD because they have ADHD, or is it because they have OCD or anxiety or anorexia or bipolar disorder? Those are the kind of ones you want to make sure that it's not primarily due to another disorder. So there's a difference between a psychiatric mimic, and a psychiatric comorbid disorder, and that influences your treatment plan. So these are ones that are, probably ones that it's good to get more consultation on. Next slide. So the etiology of ADHD, the biggest factor, there are multiple determinants, but the biggest is genetics, inheritability. ADHD is similar to height. The heritability is like 7.78, 0.73, 0.73. It changes a little bit. And again, it often runs in families. It's highly familial. But as to which genes are involved, we have polygenic risk scores now that are kind of promising in terms of teasing apart ADHD from other disorders, but they're not used clinically yet. Next slide. I always feel like I need to have at least one brain slide. But the point is that ADHD is not caused by like a specific lesion in one part of the brain. But think about the symptoms of ADHD, the cognitive and the behavioral and the attentional and the motivational symptoms. So there are multiple pathways that can be disrupted that lead to ADHD. We're most familiar with the catecholamines, dopamine, and norepinephrine. But you can have a disruption in lots of areas that lead to ADHD. Next slide. I thought I'd give you some tools that might be useful in your practices, especially for assessing symptoms and for tracking treatment outcomes. So there are a variety of ADHD scales. Some are free, some are commercially available. Keith Connors really invented teacher rating scales for ADHD in 1969 in his studies of methylphenidate. And all of the scales are kind of variations on the original scales that he developed and actually led to DSM-3. There are very specific scales like the Connors or the Vanderbilt. The Vanderbilt is nice because it's free and it gives you all the ADHD symptoms. Connors has different norms, but then there are broad scales like the Child Behavior Checklist that are good screening measures, not just for ADHD, but for other psychiatric disorders. Next slide. So this is a scale that isn't widely known, but it's one of my favorites. It's called the WFIRS, or Weiss Functional Impairment Rating Scale. And what I like about the WFIRS, it's a one-page scale, and it tells you where the impairments are. And there's two versions. There's a parent report on the child, and there's a self-report where the parent reports on themselves if you're working with an adult with ADHD. So you can just look at that right away and see problems are in school, family, risk behaviors, or if they're not, then why are they seeing you and what are the concerns? And these are available on the internet, and there's also a publisher. And the nice thing about the WFIRS and the Vanderbilt and the Connors is they're available in multiple languages. At my clinic at Children's, we have people fill those out online before their appointment, and then it really makes the appointment much more efficient to actually know that they have symptoms and impairment and what their medication and treatment history is before we see them. Next slide. I mentioned the Vanderbilt. The brief is a measure of executive functioning, which is a lot of people with ADHD have difficulties with executive functioning. Executive functioning is you have all the instruments in an orchestra, but you have no conductor. In families with ADHD, it's usually the mother that's the conductor. And you take the mother away and the kid's lost. And they go to college and they crash and burn because they haven't developed executive function skills. So it's an important target for treatment. Next slide. So teenagers with ADHD are challenging. And when I think about teenagers with ADHD, there's like two types. It's kind of like diabetes, type 1 and type 2. So there's the teenager with ADHD that had ADHD as a child, and now they're a teenager. So those are the easier ones in terms of the diagnosis. But the problem with teenagers with ADHD, especially is they don't like medication, or like most teenagers, they feel like there's nothing wrong with them, or they feel this diagnosis is being imposed on them by their parents or teachers, because originally it was. They weren't saying, treat me because I'm not doing well in school, or I'm not paying attention, or I'm misbehaving. So what happens with teenagers with ADHD is they stop their medication, and they develop other problems. So the issue with teenagers, with type 1 teenagers, is how do you engage them in treatment? And it's a different conversation. It's talking to the teenager as the patient and saying, what are your concerns? Is it sports? Is it social? And do you have concerns about the medication? Are you not gaining weight? Is there a sleep problem? And really getting them involved as a partner. So it's really how to engage them so that they're more adherent with treatment, and coming up with a system to kind of monitor their response. Let's see. Okay, next slide. So this is an example of a type 1 ADHD teenager, Justin. So Justin was diagnosed when he was a child, started on Concerta, did well, getting A's and B's, did well socially. 7th grade, got to middle school. I don't have ADHD. I'm not going to take this medicine. His grades plummeted. His parents are on his case because his grades are bad. He's hanging out with other kids. The only thing that matters to him is now he can't play sports, which he loves, because his grades are so poor. So the intervention, first of all, is getting him to realize that 36 milligrams often is not enough for a teenager. He never tried 54 or 72. We did a study of adolescents with ADHD with Concerta, and we found that most did better with the higher doses. So again, you always want to titrate till there's symptom improvement and no room for improvement to find the optimum dose. So with him, the issue was getting him to try a higher dose of medication, for 2 weeks, and then writing a 504 plan so that he could participate in sports. And then he was engaged and he was motivated, and it made a difference. Next slide. So a more complicated adolescent is someone that wasn't diagnosed with ADHD before. And it's really hard with the older adolescents. I really like the middle schoolers. I feel like they're a lot more reachable. But there's like 2 subtypes of the newly diagnosed adolescent. There's the first type, which I call hitting the wall. So these are kids who have really good compensatory strategies. Maybe they're super bright or highly verbal, or they have fantastic parents that have gotten them all this individual tutoring and support. And then all of a sudden, middle school or high school, those things drop away, and their ADHD is more obvious. This is typically, girls with ADHD are often diagnosed later because they don't have behavior problems when they're younger. And they're picked up later because they're doing poorly in school or they have low self-esteem. Sometimes it's hitting the wall. The other subtype are those that have another problem that seems more prominent, and so that's treated first. But sometimes it's just an accident of the provider they see. They have a provider that really focuses on anxiety and misses the ADHD. Or they really have significant behavior problems. The child's aggressive, but the reason that the child's aggressive is they're impulsive, and the impulsivity is what leads to it. But somehow that was missed. So these are the kind of the more challenging cases to treat. Next slide. So as people get older, the symptoms are less obvious. So I remember the slide of the 7-year-olds that were in line. You could see the ADHD symptoms and the impact. But when you're talking to a teenager or an adult, the symptoms are less obvious, but the impairment is more obvious. So again, you look for that impairment. If it's an adult, it's like, how many years did it take you to go through college? How many relationships have you had? How many times have you moved? Those kinds of things. And again, the Vanderbilt is just kind of a shorthand way to assess symptoms from different people's perspectives. And all rating scales are subject to bias. So you have to rule out, is this parent rating the child worse because the parent is depressed and angry and upset, or is this really valid? Is the teacher not rating the child ADHD because they don't know them, or they don't see them, or this child is in a class where everybody has really severe problems and the child with ADHD is the best behaved in the class? Again, so you want to interpret as best you can who's doing the ratings. And again, the Vanderbilt just gives you the symptoms from their perspective. But don't expect the parent and teacher to agree always, and don't expect parents to agree always. But it's important to understand what those differences are, what's leading to them. In terms of self-report of ADHD symptoms, so I do research on ADHD in adults, and I'd say 1/3 of people who think they have ADHD don't have ADHD. They either have something worse, or they just have symptoms with no impairment. But other people don't feel objectively they have the disorder. So self-report is good for measuring treatment response, but for diagnostic purposes, it's not as helpful as other measures. Next slide. So now we'll switch to talk about treatment. So the strongest evidence base for ADHD are medications and behavioral treatment, but behavioral treatment doesn't really address the core ADHD symptoms. It addresses some of the impairments, like family functioning, behavior problems, completing work, those sorts of things. Most effective interventions are behavioral parent training and classroom interventions. Organizational skills training, for an adolescent that's motivated, it's helpful. But these things are very tedious. They're often, people view them as boring. You really need someone that really wants to work on those things for them to be helpful. And there are lots of things that have been shown not to work. Again, most things that are done in an office, counseling, therapy, have not been shown to work for ADHD. Neurofeedback, there are now Endeavor, which is a computerized game where kids kind of do ski down a iPad. It doesn't really affect core ADHD symptoms that much or impairment in other settings. So again, the most evidence is for medications and behavioral interventions. And then what I think is probably the most helpful thing for treating ADHD is focusing on their strengths. Not just focusing on what's wrong, but finding out what their talents are and emphasizing them, whether it's their socialization, whether it's math skills, whether it's sports, and making sure that those things can advance. So at our clinic, we have what's called a stepped care model for behavioral treatment. What it does is it starts with less intensive interventions. We have a class for parents where they learn behavior modification skills. We call it super parenting. And you don't even have to have a formal diagnosis. You just have to have some symptoms and to be referred. But then for kids that are really severe, who have ADHD, for example, and aggression, or who don't respond to super parenting, then we have another program called Incredible Years. But the idea is that this kind of coaching and guidance for parents needs to be individualized based upon kind of the severity. And what we do for our waiting list is there are a number of parent training books. There's one called Your Defiant Child by Russell Barkley that we often recommend, and there are some websites we direct people to. But parents are desperate. They go to the internet and they find 10 different books that tell them 10 different things, and that's really not helpful. So we often recommend CHADD, which is a support group, chadd.org, for parents of kids with ADHD, and they have very good resources. So let's talk about medications. We know a lot about ADHD medications, but not as much as we should know. When we think about ADHD medicines, there's 3 classes of medicines. We have 2 stimulant classes, the methylphenidate stimulants and the amphetamine stimulants, and then we have the non-stimulants. So there are many different FDA-approved medications to choose from. Within the stimulant class, there are short-acting or immediate-release formulations, like Ritalin or Focalin. Then there are intermediate-duration stimulants that last about 8 hours in terms of their behavioral half-life, and that would be Focalin XR, Metadate CD, those type of medications. And then we have the longer-acting. We used to call them once a day, but we realize they're not really once a day for many people. But the longer-acting ones last 10 to 12 hours, and that would be Concerta, Vyvanse, Mydayis. So there's many stimulant and non-stimulant medications. Usually we recommend a long-acting stimulant. There's no need to start with an immediate release for kids older than 6. And the problem with the immediate release stimulants is then you have more wear-on and wear-off effects. First-line treatment is usually a stimulant, a long-acting stimulant, although there are cases that you want to consider a non-stimulant. In terms of the non-stimulants, there's a couple different options. There are the alpha-2 agonists, which have been used off-label to treat ADHD for a long time, clonidine and guanfacine. These are blood pressure medications, and they kind of slow kids down, and they can reduce irritability. They are not really good for attention, so that's why we don't recommend them, especially for adolescents or adults. Their side effects are different than the stimulants, sedation, somnolence, fatigue, and they can be given at night. and they can be combined with a stimulant. And many times you can use a lower dose of a stimulant during the day when combined with an alpha-2 agonist. Then there are also two non-stimulants, Strattera and Qelbree, which are effective for both attention and hyperactivity symptoms. Strattera has been around a long time. Qelbree is fairly new. What's nice about these options, those medicines, they don't have any abuse potential, and their side effect profile is slightly different. They don't impact sleep at night. And they don't impact sleep onset, I should say. There are other sleep effects that they have. But so there are many different medications to choose from, and many different formulations. And there are pills, patches, liquids, lots of different delivery mechanisms. So what stimulants do is they really acutely impact core ADHD symptoms. They also have impacts on family interaction and teacher interaction. When a child is taking a stimulant, parents are more relaxed, they're more positive. They also impact handwriting. So kind of a simple thing to do in the office is to have a child write their name or write a sentence. And you'll see improvements in that. So these are what the stimulants do. And the stimulants have a very discrete on-off pattern. And so it's really important that the stimulant fit the duration of impairment. So if you have someone that has mild impairment, mainly at school, and they're a small child, they don't need a 12-hour stimulant. Maybe they need an 8-hour stimulant. On the other hand, if you have a 7-year-old Evel Knievel child that is always going to get in trouble and is dangerous, they probably need to be on a longer treatment. Or if you have a college student that is doing most of their studying in the evening, they might need a longer stimulant or something with a patch that they can control the onset. And then adolescents, you worry about them when they driving. You don't want them to be driving when the medication is wearing off. Stimulants have withdrawal effects which are not really great. So, next slide. Just a few principles about medication treatment. The most important thing about a stimulant is finding the right dose, is titrating. So we always, when we talk about medication with the family, we always say we're going to recommend a stimulant medication trial. And what that means is trying 2 or 3 doses, usually for a week apiece. And then we want you and the child's teacher to let us know which was the best. You don't want to just give the lowest dose and stop. You might not have any tolerability issues, but you're not going to be effectively treating the ADHD. So again, you want to titrate to the optimal dose. Amphetamines are twice as potent generally as methylphenidate, so you use kind of half the dose with an amphetamine that you do with methylphenidate. And there's a large degree of variability in terms of how people respond in different doses. And then we recommend monitoring cardiac functioning and growth because the most common side effects of stimulants are decreased appetite, and they can increase your heart rate, increase your blood pressure a little bit. It's usually not clinically significant, but it's important to monitor. And sometimes we find people that have difficulties that need to do something different. The effect size of stimulants, effect size is a statistic that tells you kind of how effective the intervention is. And for stimulants, it's 1, which is really large. For antidepressants, it's 0.4. Just a placebo is like 0.39. So it's among our most effective psychiatric medications. So do you start with a methylphenidate stimulant or do you start with an amphetamine stimulant? We usually recommend methylphenidate for children, and then if they don't respond, then we go to an amphetamine. This is a study I did where I compared 3 different doses of Focalin XR with Adderall XR. And at the group level, they were equally effective. So this is the ADHD rating scale. Anything above 20 means you're in the ADHD range. And you can see at placebo, there was a lot of improvement. At 10 milligrams, similar to placebo. But when we got to 20 milligrams, the majority were normalized in terms of their ADHD symptoms. So even though at the group level, there was not a difference between amphetamine and dexmethylphenidate, 37% of the patients did better on one versus the other. So again, if someone doesn't respond to one class of stimulant, try another. Sorry. So the main side effects we said are decreased appetite and difficulties with sleep onset. Usually those wear off, but not always, and you have to do different interventions. So if they're we get concerned if they're losing weight, and so really tracking their growth. The other common side effect are rebound symptoms. So as the stimulant wears off, you see more irritability or mood symptoms. And the parent will come in and saying they're worse, but you'll find out, well, at school they're doing better. So that's rebound, not this medicine not working, and you have a different strategy for rebound, such as adding either a low dose of a stimulant or adding an alpha-2 agonist when the medication is wearing off. Everyone's worried about misuse and diversion, so it's really important, especially for adolescents, to really be counseled about keeping their medication secure and not sharing it with friends, making sure that it's locked up. It's a huge problem in college students, and getting your patients treated in college is always a challenge. So think about a non-stimulant. Again, if someone doesn't respond to a stimulant, or they have severe sleep problems on a stimulant, or you're concerned about diversion or abuse. I think those are the main ones. And then there are situations where we combine stimulants and non-stimulants, when you want longer action or you're trying to target several different things. We used to worry about cardiac effects. I mean, 15 years ago, there was this worry that everybody needed an EKG. It was like welfare for cardiologists. Now we realize that stimulants are generally very well tolerated and when medically monitored. So what you want to make sure is someone doesn't have a cardiac, structural cardiac problem or like a arrhythmia that you don't know about. And so we always ask about family history. And if there's a family history of those things, then we do tend to get an EKG first, but otherwise we don't. And we see lots of children that have had cardiac surgery and they have attention problems and learning problems that are really affecting the quality of their life. And we will use stimulants with them, but just more cautiously. Next slide. So I want to make sure we have time for questions. So some takeaways. ADHD is common in all age groups. The symptoms vary, though, but the impairment is consistent. You'll see that over time. And again, ADHD is not a benign disorder. And so it's not something that you should ignore when you see ADHD symptoms, because you can really change people's lives in a very positive way. And again, learning from family history, like who else has symptoms or who else has struggled with it. We like to combine behavioral with pharmacological treatment. And monotherapy by itself is usually not that effective. Okay, next slide. I think I said that. I just want to mention some of the research that we're doing in ADHD. We're doing a study, it's called TPAC, for treating parents and children with ADHD. And the idea of the TPAC study is young kids that have ADHD symptoms, like 3 to 8, the medicines don't work as well in kids under 6. So in TPAC, what we're looking for are children with ADHD symptoms that are not treated, who has a parent with ADHD that's not treated. And in the TPAC study, what we do is we evaluate the child and the parent, and if they're eligible, half the parents get a medication trial and then get 10 weeks of behavioral parent training, and the other half get behavioral parent training. So just if you have any patients that you think might be interested, we'd be happy to see them, and they'd be seen very quickly. And the treatment is done via telehealth. You can just email me if you have questions or have someone that might be interested. And there's the number. And we just started a new study of trigeminal nerve stimulation for ADHD. And we're looking for 8 to 12-year-olds who are not taking medicine, who would be good candidates for this stimulation study, which involves 4 weeks of treatment. And again, this is at no cost to them. But